Thank you so much. And I think while he is setting it up, I would still like to congratulate the organizers for trying to hold this master class regularly every year, and along with the year-end review, it is one of the best teaching programs for interested residents and fellows. So I hope you keep it up. Okay, thank you. All right, so the topic given to me was selection of first-line immunotherapy for Pdl1 positive metastatic non-small cell lung cancer without an oncogenic driver alteration. So I will try to answer 3 questions in 10 minutes. First, is immunotherapy effective in Pdl1 positive metastatic NSCLC? Second, is immunotherapy effective as monotherapy or as combination treatment? And third, how to decide the choice of agent or regimen. So the first question, is it effective in Pdl1 positive NSCLC? And so pictures speak louder than words. Was a 55-year-old lady who presented with metastatic disease, very high Pdl1. In fact, the highest which we have seen so far, 100% by sp263 and 90% by 22C3. NGS was negative, and you can see the responses in the lower field 3 months after monoimmunotherapy with pembrolizumab. This was after 8 cycles, and you can see she had a PET scan by chance, and you can see in a period of 7 months the stark benefit which is there. And another imaging after 12 cycles of pembrolizumab monotherapy, sustained PR almost like a CR, and she continues to be on monotherapy and is doing well. So the answer to the first question is yes. Second question, is immunotherapy effective as monotherapy or as combination treatment? 3 years back we tried to address this in a review, and this algorithm may have become outdated in just a period of 3 years, but the bottom line is that based upon Pdl1 score 50% or more versus less than 50%, you could choose on giving monotherapy with an immune checkpoint inhibitor versus combination. The important thing is to rule out an oncogenic driver alteration, because if that is present, the preferred treatment becomes targeted therapy. Of course, you can still consider using the combination even with high Pdl1 if patients are in good performance status and on a clinical judgment have rapidly progressive or high burden of disease. But molecular testing for oncogenic drivers, especially EGFR and ALK, is mandatory and preferably for the others, and this should be done for all non-squamous histologies and selected squamous histology. So in the absence of contraindications or any issues related to affordability or access to treatment, monoimmunotherapy for Pdl1 greater than 50% and chemoimmunotherapy for Pdl1 less than 50% remains the preferred treatment for metastatic NSCLC. And again, re-emphasizing, it's essential to rule out presence of the most frequently occurring oncogenic driver alterations prior to initiating immunotherapy. Especially because the EGFR prevalence in our setting is close to 30%, ALK around 10%, and they are, as of now, largely mutually exclusive. Now, just a little more detail about the 2 monoimmunotherapy trials. This was the Keynote 024 trial, the first trial looking at monoimmunotherapy for high Pdl1 NSCLC. It published initially in 2016, and 2 years back the 5-year outcomes were presented. And if you can look at the graphs on the right side, the A is the overall survival and the lower one is progression-free survival. You can see it really works with the median OS doubling from 13 months to 26 months and a very impressive hazard ratio of 0.62. PFS, again, a very impressive hazard ratio of 0.5. This was the other trial, atezolizumab for Pdl1 positive NSCLC, Empower 110. And as you can see, this the primary analysis published in NEJM 2020, and high Pdl1 did tend to do better with the OS between 20 months versus 13 months. Now the problem for this trial was again the biomarker, as Dr. Rajiv Kaushal was telling, and you had SP142, which was the companion diagnostic for atezolizumab, but since it's no longer really used widely, so they also cross-checked with 22C3 and SP263, and there were overlaps. And so if you looked at the analysis based on the other two markers, I don't think you'll be able to see it very clearly, but the responses were largely similar. And this was the overall survival published in Journal of Thoracic Oncology in 2021. And so if you looked at the overall survival for 22C3 positive Pdl1, it did seem to indicate that there was a survival benefit. Obviously, they did a lot of biomarker analysis, and what emerged from other immunotherapy trials was also seen to some extent here, that the higher the Pdl1 expression, the better patients seem to do. So the answer to question number 2 is monotherapy for high Pdl1 expressors, but important to rule out presence of an oncogenic driver alteration, and chemoimmunotherapy for Pdl1 expression less than 50%, unless they are deemed to be unfit for the combination. Question number 3 is how to decide the choice of agent or the regimen to be used. And so we have seen rapid progress in the last 7 years for immune checkpoint inhibitor therapy in the first line setting. And at ASCO, our expert panel published this living guidelines. So if you see, this was what we published in Journal of Clinical Oncology last year, and multiple regimens are listed here. And the rapidity with which advances occur is so much that the current update which we brought out this year, the Poseidon trial as well as the Empower Lung 3 also got published and had to be included. But I'm going to focus on the ones which are the most common. And so if you look for non-squamous NSCLC, you can see that you have, for high Pdl1, you have the monoimmunotherapy trials listed along with the combination trials. And for the low expressors, you have the combination trials which are listed. For squamous, the choices are much less than for non-squamous, and the Keynote 042 trial is one which has been used in all settings, and I'll come to that in a little bit of detail. And so I've already told you in detail about the two trials. There are actually several trials which have been done, but we'll restrict this to the two commonly used drugs. So the Keynote 024 was looking at Pdl1 50% or above. The Keynote 042 included all Pdl1 positives. Empower 110 also included all Pdl1 positives, but the benefit was all driven by the high Pdl1 expressors. And therefore, as of now in routine clinical practice, I think the dictum of segregating at 50% is what holds true. If you look at chemoimmunotherapy, non-squamous metastatic NSCLC, again, a big combination variety, but let's restrict to the ones which are most common. So you can see that the Keynote 189, which combines pembrolizumab with pemetrexed platinum, is the one which really stands out. For the trials which have used atezolizumab, the hazard ratios have all been 0.8 or higher. Some of them have not reached statistical significance, vis-a-vis the pembrolizumab trial, in which the hazard ratio was much more impressive at 0.6, and you can see the graphs which are strikingly more impressive. If you look at squamous disease, again, several trials, a lot of the drugs are available only in China, so we'll restrict to the two commonly used drugs, pembrolizumab and atezolizumab. Pembrolizumab here again performed very well with a hazard ratio of 0.71. Atezolizumab actually did not reach statistical significance for squamous. We don't know the reasons. They were the same drugs, chemo drugs which were used. We don't have the answers to that. Dual immunotherapy, just a word about it. You have the Checkmate 227 and the Checkmate 9LA. The 227 was one of the most complex trials ever designed for reasons best known to the sponsors. And though the approval stands for using it in Pdl1 positive, the benefit is actually better off in Pdl1 less than 1%. The 9LA was a different approach, combining it with 2 cycles of chemotherapy and then continuing the immuno checkpoint inhibitors. Again, I do not see what relevance these have in day-to-day practice as of now. And the important thing to realize is that we say that immunotherapy has no role in pre-treated patients with immune checkpoint inhibitors, but we also need to realize the fact that in our setting, most patients may not have received immune checkpoint inhibitors in the first line setting, and therefore in second line, there is a case for offering that to patients. Affordability and access obviously remains a very big issue. So to summarize, first line treatment options for metastatic non-small cell lung cancer without an oncogenic driver alteration, it is monotherapy with a PD1 or a Pdl1 immune checkpoint inhibitor for high expression, which is more than 50%. You can consider combination of chemo immuno for such patients if you have a significant disease or symptom burden. The combination is the standard of care for Pdl1 less than 50%, but if you have patients who are unfit for combination, you could consider monotherapy with one of these agents. And the clear role for dual immunotherapy as of now remains undefined. Importantly, do not act upon high Pdl1 values and do not initiate immunotherapy in lung adenocarcinoma and other non-squamous histological types until the results of EGFR and ALK testing are available and are negative, and the 3 A's related to immune checkpoint inhibitor treatment need to be kept in mind, which is access, affordability, and adverse effects. And lastly, I will leave you with this slide, which has on a different topic altogether. This month was the hottest day since records began, and we have seen the effects of climate change occurring in all continents across the world. Thank you so much.
Thank you, Dr. Navneet, for providing that crisp conclusion. Definitely, we'll always keep debating because we're still struggling with the biomarkers, actually. So next, I would like to invite Dr. Amol Kotalwar, consultant medical oncologist from Solapur. He will be speaking about selection of first-line immunotherapy in Pdl1 negative and non-driver mutation. Ajay, okay. So Dr. Amol is not there. So this topic will be covered by Dr. Ajay Kumar Singh, a consultant medical oncologist from Tata.
Sorry for the last minute change. Amol is not available. Navneet sir, I have one question for you. If patient is having upfront brain mets and Pdl1 is around 90%, so which will be the preferred drug between these 3 red drugs, that is atezolizumab, pembrolizumab, or nivolumab? Is there any data to prefer one drug amongst the other for brain mets, upfront brain mets?
I am not aware of any specific. Very good question. I am not aware of any specific differences related to CNS activity between these drugs. We have never had such a discussion, even when we have been discussing the guidelines and formulations, but if you have knowledge, please, I would be happy to know.
So recently I had a question that I thought.
So again, I told you, very good question. I don't have the answers. I am not aware of any differences, and so you would treat the way, the amount of brain involvement is not going to determine the choice of therapy here. You will have to, immune therapy can have very good brain effects, effects on brain metastasis also, but if you have symptomatic brain mets, you would be tempted to treat them first and then go on to therapy.
Thank you, sir.